Good morning, good afternoon, good evening, brothers and sisters, depending upon which time you're watching this video. For those that don't know me, my name is Brother Joshua Schmidt. I am a professor at Yavapai College. I mainly teach anatomy and physiology, but I also teach a little bit in our EMS department, as well as our law enforcement academy. I have a lot of other roles. I'm a certified athletic trainer. I've been an instructor for the Red Cross for almost 20 years now in various different capacities. I've done search and rescue with the sheriff's office for about 20 years now, and for like the last 4 or 5 years, I've been an operator medic on our SWAT team in the sheriff's office. So a lot of background in tactical medicine, as well as just general first aid, CPR, sports medicine, and wilderness medicine. So a little bit about my background. The purpose of this video is just to let you know about the different equipment that we've recently installed in all 3 of our stake buildings, the Chino Valley building, the Stake Center, and then the Prescott Valley one off Longview, I believe is where it's at. Anyways, so I'll go through a few things here and we'll talk about it and have some videos. Here are the new wall cabinets. These are our new defibrillator wall cabinets. You can see they have a bunch of different supplies in them. We're going to go through some of that. Basically on this top shelf, what you're going to have is you're going to have an AED. You're going to have a little black bag on the top of that AED that's connected that's going to have a pocket mask, gloves, a razor, some of those different various things. And then for our higher level healthcare providers like nurses, paramedics, EMTs, things like that have gone through like BLS, basic life safety, and maybe even advanced life safety, we have a bag valve mask over here. So I wanted to have that tool available for those that have that training. Lay rescuers, you probably have never seen that and don't know how to use it, so don't worry about it. But there's also a pocket mask in here as well. On the bottom shelf, you're going to have the alarm over here on the right, and you'll see a video of that in a minute, how to shut that off if you need to maintain it. This runs off 2 AAA batteries. So if you're one of the members that is in charge or gets tasked with checking this AED from time to time, that's where you can shut off the alarm. And there again, there'll be a little video here in a minute showing that. I left an alarm in there because, little kids and things get curious. They like to open cabinets up. And so if it opens up for an emergency for you to grab it, it's going to alert everybody around because it has kind of an annoying high-pitched sound. Again, you'll hear that in a minute in a video here. Or also it will let us know if, people are getting into it that aren't supposed to be getting into it. So again, on the bottom shelf, you will have 2 individual first aid kits. They are going to have different types of contents in it. The one on the left is a prepackaged one from North American Rescue. It'll have scissors, foldable gauze. It's going to have a tourniquet in there. It's going to have some various dressings, things like that. The one on the right is a custom kit that I put together. Again, trauma shears for cutting off clothes, things like that. You'll also find a pair of shears in this black bag as well. It has an abdominal dressing for open, wounds on the abdomen. It has Celox, which is a clotting agent, a hemostatic dressing for wound packing. And again, we'll have some training and videos on that. It has another tourniquet, it has some chest seals in there, and then it has just a roll of general gauze. This will also have gloves in it. This particular image doesn't show that. And it'll probably have some 4x4 just general gauze in there as well. So all of your major medical emergencies, or 90+% of them, this cabinet should be able to help you in the first few minutes until EMS arrives, like our ambulance company, our fire engines, law enforcement, those kinds of things. So it's to bridge that gap from time of incident of either trauma or medical call to where the fire department, EMS, and law enforcement gets there. So here's our locations. So you can see that the cabinet, these cabinets are going to be centrally located in the buildings. This particular one is showing the hallway of the Chino Valley building. So this is coming from the chapel, looking down to the relief sighting room there. And here, again, it'd be this door, which we can see right here, is the library. Our goal is to put all these by the library so that they're, most members know where the library is at and they're centrally located. And you can see this one happened to work out really nice that there's a fire extinguisher right next to it as well. So you kind of have a one-stop shop for bad days, right? I'm going to go through some other videos, and this will go into some training of like how to use all the equipment in there, how to use the AED, special considerations, all that kind of stuff. So I'll go through this PowerPoint, and then we'll have a couple of videos of me showing all that stuff. And then look for in the future a live Google document of some nature that will have the ability to sign up and actually take a hands-on class if that's something that you would like to do, if you're not already or have never taken like a CPR AED class and a stop the bleed class. So hopefully you guys get a lot out of this training. If you have any questions at the end of this little video, I will put all my contact information so you can contact me if you have questions, because I'm also an active shooter instructor and have a lot of experience in all those areas as well. All right, I told you I'd show you a video of how this cabinet works, so hopefully this audio will pick up. We're going to watch this real quick and kind of take you through. If you're one of the individuals that either needs to come shut this alarm off to service anything in there like the AED and all that, or if you need to shut it off to change batteries or whatever it might be. All right, as you can see, if you have to maintenance this, right now I have the alarm off, but you'll pop this latch. Normally this little alarm will be on. There's a little button here. It's activated by this magnet right here. As you shut it, it turns off. So this will normally be on, and obviously that was. So you can see, again, this is showing you just how to get into that cabinet if you need to switch that alarm off. One of you will be tasked, someone in each ward basically will be tasked to check this monthly, and I'll have a separate additional training and video on how to do that. So let's go through a little bit and talk about how, switch this real quick, how our kind of assessment should work. So this assessment will work for medical calls, heart attack, stroke, someone passing out, all that kind of stuff. First thing we want to do is we want to make sure the scene is safe for us to act, right? Watch out for any hazards. I can tell you the couple of times that I've almost been killed in my career has always been on like a traffic accident where I get out and I go to render aid, mainly in a civilian capacity. Traffic gets backed up, and then I kind of lose my situational awareness as I'm working on that patient, and pretty soon traffic clears up and I look up and now there's cars flying by us at 60 miles an hour. So be diligent with that and know your surroundings. Luckily, church is usually a very safe place, and so we hopefully won't have to worry about scene safety too much, but keep an eye on that. And then we want to put on protective equipment. So this is where our gloves come in. Again, that black kit that's attached to the AED will have gloves, and both first aid, what we call IFACs, individual first aid kits, will have gloves in them as well. So the first thing we're doing our patient is we're going to come up and we're going to tap and shout them. I usually like to tap somewhere up on the shoulder, kind of that clavicular area or the collarbone or the sternum. Just, hey, sir, ma'am, sister, whoever, brother, whoever, are you okay? If that doesn't work, will usually some type of painful stimulus. A sternal rub works really well. I'll take my knuckles and just kind of dig them into their sternum, and hopefully that painful stimulus will kind of get them up and moving again, right? If that doesn't work and they're non-responsive at this point, we want to notify EMS. This is where we're going to call 911 and maybe have someone call 911 on our behalf so that we can continue down our assessment. Then we're going to move into opening the airway. And so if you've had CPR a long time ago, we used to do ABCs. Now we do CAB. We're going to look for circulation. Part of that initial sweep, and I'll show you a video of how to do a blood sweep here in a few slides. But we're going to come up, we're going to just look the body over real quick and make sure there's no massive bleeding. And then we're going to open up the airway with a head tilt chin lift. We're going to look, listen, and feel for breathing. And we're going to check for a pulse at the same time. So we're looking for that chest rise and chest fall. We're feeling for that airflow on our cheek. And again, we'll have a video of me showing how to do all this here later in this presentation. And then we want to feel for that movement of that air. And then while we're doing that at the same time, we're going to come, if it's a child or an adult, again, child is essentially, well, there's a slide here in a minute that talks about this, but child is basically signs of maturation. So kind of 12 and older. I'm sorry, an adult is 12 or older, signs of maturation. A child is at 1 to 12, and then an infant is less than 12. So if it's an adult, we're going to, and or a child, we're going to check at the carotid artery on the neck. So we're going to check a pulse at the neck using anything but our thumb. If it is an infant, we're going to check at the brachial artery, which is down on the arm. And again, I will show this here in a minute. So we're going to check all those signs of what we call life. If they're not breathing, they don't have a pulse, we're going to start CPR and we're going to acquire that AED. So again, here we can see, 12 and older are what we call signs of maturation. This is breast development in a female, Adam's apple development in a male, maybe chest hair, facial hair, those kinds of things. We're going to treat them like an adult. And we want to compress that chest from 2 to 2.5 inches. I really like what I use is I like to just say about 1/4 to 1/3 of their overall chest depth. So in this little picture here, we can see like from the back to the top, let's say that's 10 inches. I want to compress that chest anywhere from roughly about 2.5 to 3 inches deep, depending upon the size. So I really like this down here, like a quarter to a third of their overall chest depth is what I'm going to compress, because it's really hard to remember, like 2.5 to 3 inches, whatever it might be. So, but it is 2 to 2.5, 1.5 to 2 inches, and 1 to 1.5 for an infant. So child is 1.5 to 2. Again, the bigger the kid, the more we're going to have to push. The smaller the kid, the less we have to push. And an infant is 1 to 1.5. The way I categorize these is signs of maturation. It's adult, no signs of maturation, but they're not. They're supposed to say walking. Well, that's a typo, sorry. Should say walking. If they're walking, we're going to treat them like a child all the way up to that sign of maturation. And if they're not walking or less than 1, we're going to treat them like an infant. Most kids kind of walk around the age of 1, so that's kind of what I use as my filled summary, just to put that into perspective. So if we're doing CPR by ourselves, our ratio, if we're going to do breaths and we're not just going to do compressions only, again, this is if you've had a formal class like BLS level, is 30 and 2. You can perform compressions only. So if you've never had training and you're like, I don't really know what to do, you can just do compressions on the chest, and that is going to be very adequate. A lot of our literature has shown that the most important thing for a cardiac event, if we're going to come in and use an AED and their heart is stopped, is getting that pump working, right? So when we compress the chest, we are forcing circulation throughout the body, and the more perfused the heart is, meaning the more blood flow that we've pulled into the heart through those compressions, the greater the chance of this guy working right here, which is an AED. So we're shooting for 100 beats per minute. What I like to sing is Staying Alive. So, staying alive, right? That's going to put you on a really good pace. Most of our AEDs, once you turn them on, have what we call metronomes built into them. So when it's not shocking, it's going to give you a cadence count of like tick, 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 tick of that like clapping, rhythmic progression, so you can kind of keep up pace. So the whole goal is to get this AED in here, because when we go into early cardiac arrest and the heart stops, every minute that goes by, the chance of survival goes kind of down the drain, about anywhere from 5 to 10%. So, an average response time of EMS at most of our buildings is probably somewhere between 3 and 4 minutes, because fire stations are pretty close to a lot of our church buildings. So right there, if you have a massive cardiac event at church, you have about a 50 to 60% chance of survival without the AED. With an AED in the building, it goes significantly up for things like ventricular tachycardia, ventricular fibrillation, these kind of early cardiac arrest arrhythmias that tend to manifest themselves in the first 5-6 minutes. So big thing with an AED is you're going to get the AED, and again, I'll show a video of how to use this here in a minute. You want to turn it on and then just follow the directions. They are automated, and so they will literally talk you through everything, where to put the pad placements. There's pictures. It's really hard to mess up. So with very little to no training, you can pretty much use an AED. They're not hard. And so again, I'll show you guys how an AED actually works, and we'll go through a video here in a minute. And I'll talk about considerations in that video, but basically you want good pad placement. So you're looking at, this is the patient's upper right chest and lower left chest. We want this pulse, or this electrical impulse, to go through the chest, come from the upper right to the lower left. So one consideration is if you have a small kid, you can absolutely use an AED on them. So let's say it's a 2-year-old, but these pads are going to be so close that we won't get good electrical shock. So what we need to do is we need to put one in the front of the chest and one in the back of the chest. Maybe they have a necklace. If they have a necklace, we want to flip that necklace over. It doesn't need to come off. We just want to get it out of the path of the current. If they're really hairy, maybe they're a big, burly, hairy-chested person, then we want to make sure that we get good pad placement. So you might need to kind of take some of that hair off. We just need to have the pad sticking well to the skin. If it's riding on top, billowing up, then we need to kind of remove some of that hair. Females, a lot of times they wear underwire in their brasiers and underwear, and that wire needs to come off. So that's why those trauma shears are in there, so we can get all that clothing off. I know as Latter-day Saints, we are very modest people. This is one of those times that we want to get the chest bare. And so that clothing needs to come off. Do the best you can about not letting a lot of people look and be gathered around. But at this point, like if I come in as, an EMS crew, like that's the first thing I'm doing is going to cut their clothes off so I can find my landmarks. I can get good pad placement and all those kinds of things. So any jewelry, any necklaces, anything that's draped across the chest needs to come off. If it's small things, like maybe someone's got, a sternal piercing or something like that, which, you might run into if it's a visitor, whatever it might be. If it's smaller piercings, it's no big deal. But large necklaces, things like that, underwire and brassieres, those kinds of things need to come off the chest and get exposed. Males especially, but females can do this too in cardiac arrest. A lot of times they'll sweat. And so you may have a whole bunch of like sweat like water on the chest, which will impede the pads from having good placement. Again, that's why that gauze is in there. I'm going to put little towels inside of the AED cabinets as well in those kits so you can just wipe their chest off. They can be wet. It's just we don't want it to be wet and slimy where the pads are so they don't get good contact. So we just want to dry off those areas where the pads might be. The last one would be medical patches. So again, like nitro patches are commonly worn on the chest. Some females will wear birth control down around the hips and those kinds of things. We want to take those patches off for a couple of reasons. One, a lot of medications are polarized, and so we're putting a big direct current through here, and that may cause the medication to drive into the skin and take a big, dosage of that medication. Some medications are flammable, and we're putting a current through here, which is not a good idea, so we want to remove those. Again, that's really important that we do it with a gloved hand because those patches are absorbed transdermally through the skin, so we don't want it to get into us. So if it's nitroglycerin, it's a big vasodilator, and if we took a big dose of that, we may pass out ourselves. So make sure you're using gloved hands to remove all that stuff. As far as wound trauma, so again, I'll show a video going through all the medical on how to do compressions, open the airway, all those kinds of things. For a wound care kind of trauma, so let's say, penetrating trauma, like maybe someone falls and cuts themselves open on a pew, maybe they, whatever, they're getting big bleeding, those kinds of things. If we look at the statistics on survivable traumatic injuries and quick intervention, right? So we're going to do something quick to save this person's life potentially. There's 4 things we really look at. The number 1 thing that kills people is bleeding. Number 2 is airway compromise. Number 3 is tension pneumothorax. That's some type of penetration into the chest wall where we're bringing air and it's starting to collapse and put pressure on the lungs and the heart. And then the last one is hypothermia. These are the 4 things that kill patients if they have what we call a potentially survivable injury, right? A traumatic injury. So for bleeding, our go-to is direct pressure, right? I come in here, I put some pressure on it. If you have a large bleed, like a large arterial bleed or a large venous bleed, then we need to do something more than just pressure because that pressure might not be enough to stop that bleeding, especially if it's a large wound. Like maybe it's a gunshot. Heaven forbid that we have an active shooter in one of our buildings, but if we have a lot of gunshot victims, like that wound channel might be so open that pressure is not going to be enough. And so in that case, we're going to go to some of our advanced bleeding control systems. For our extremities, we're going to use a tourniquet. This is a soft T tourniquet. The ones that you have in our AEDs are what we call CAT tourniquets, combat application tourniquets. And there's a whole video here in a little while of me going through how to use a CAT tourniquet. So we're going to put a tourniquet and we want to put it on high and tight, up as high on the arm as we can and on the leg. And again, there's a video going through that. If it's somewhere that we can't get a tourniquet on, like maybe it's our pelvic girdle or our scapulothoracic articulation area, which is a fancy term for the shoulder blade, in the shoulder complex, if it's up in there where we can't get a tourniquet on it, then we're going to pack that wound. And there's a whole video of me going through wound packing. So in order to open the airway, again, we're going to do that head tilt chin lift, just like we did with CPR. So after we get bleeding controlled and we get all of our blood sweeps done, then we're going to move on to the airway. If we only have one patient, we can 100% hold the airway. If we have multiple patients, we're going to use the recovery position because I can't sit here and hold their airway open. So let's say 4 or 5 people get hit by a car and they all have trauma. I'm going to have to put one of them as soon as I'm done with my assessment in a recovery position and move on to that next person that's bleeding, right? If I only have that one patient, then I can do one of these more advanced airways where I can hold them and do compressions and all those other things if they need it. And then a tension pneumo, again, is some type of penetrating trauma to the torso. And basically, we're going to include the base of my neck, kind of where your sternum starts, your breastbone, all the way down to my belly button, 360 degrees around. Any cuts, scrapes, tears, punctures, anything in that area, in a trauma-related event where our patient's not doing well, right, we're going to seal these up because we don't want air getting into this open hole and coming into the chest cavity and potentially setting us up for a collapsed lung that builds up pressure, that puts pressure on the heart, and we end up with a tension pneumothorax. You can use pre-manufactured chest seals. We'll have chest seals in our cabinets. You can improvise something with some tape and what we call an occlusive dressing. It's just a fancy word for non-breathable. You can use packaging. You can use the gloved hand in a pinch. There's a lot of ways to accomplish this, but we're going to seal that up. And then last but not least, we want to think about hypothermia. This patient is 100% going to be going into shock, and they're going to be pulling blood from their extremities into their core. And so it's really important that we keep them warm because they're going to lose heat fast. A lot of times they will feel hot and flushed, but when you touch them, I promise them they're going to be cold, even on a warm day. So we might be sweating our keisters off, right? But this patient's probably going to be cold. And so we want to preserve that heat. And the main reason is when our core temperature falls to about 95 degrees Fahrenheit, we start losing significant clotting ability. And so whatever blood's left in their body, it's not going to want to stick together, and those platelets don't want to come together. It's a form of clot. And so we want to keep that patient warm. All right, that's the end of that presentation. And again, I'll have a couple videos after this showing how to use these and going through them. So hopefully you guys enjoyed that. All right. Welcome, brothers and sisters. This video and the purpose of this is to go through the first aid component that you'll find in the new AED cabinets. So I'll show that in a prior video or later video of like kind of what's in there. What you'll see is, and this is an empty one, you're going to see two kits. You're going to see a kit that looks like this that has a pair of trauma shears, little scissors in it, and then you'll see a vacuum seal kit. They essentially house the same thing. I kind of made a custom kit, and then we bought and purchased a pre-manufactured kit. I'll show a picture of that here later in this video of like what the contents of that vacuum seal kit are. But I wanted to go through a real quick first aid. So when you open this up, you're going to find these components. You're going to find just a general gauze type abdominal pad for like open wounds on the abdomen. You're going to find some Celox, which is a hemostatic type gauze for if you have a big bleed in certain areas that we'll cover here in a minute. You're going to have 2 chest seals to seal up anything on the chest. You're going to have a tourniquet, and then you'll just have some random gauze and gauze pads and gloves and things in there. So if we have a trauma type patient, not a medical, we're going to do medical in a different video, which have been the video before this, but a trauma patient, right? So big bleeds. Maybe they fall and they catch their arm on the edge of a pew and they tear open their axial arm artery here, or whatever happens, right? Maybe they're out riding a bike and someone hits them with a car in front of the church parking lot. Lots of different things can happen. When I come up on my patient, there's certain areas I'm going to check. The first thing I'm going to check is big bleeds. And I'll show this in a PowerPoint, but basically we have 4 things. If a patient can survive a trauma, there's 4 things that will usually kill them first. And we use a bath assessment, and that's bleeding, airway, tension pneumothorax, and hypothermia. Bleeding by far is the first, and someone can bleed out really fast if they get a big vein or a big artery. So I'm going to come to the legs. If I see an active bleed on the leg, I'm going to first try pressure, right? If that's immediately overwhelmed, and you'll know when it happens, it's going to be a big bleed. What I want to do is I want to go to my tourniquet, right? So I use tourniquets on my legs and my arms. Those are the 4 areas. When they're in the kit, they will look like this. They'll be folded up. They'll be halfway overlapped with the windlass tucked in and the windlass keeper off to the side. This allows me to put it on myself one-handed if I need to, or I can fish it over, but I can absolutely undo this if I'm putting it on another person, right? So let's say I'm going to do this right leg. I apologize for Dummy Dan, he doesn't cooperate here. But if I'm going to put it on the leg, a lot of times you might have, angulated and deformed, appendages, something like this. And it can make it hard to get over their foot and their shoe and everything and get up here. So it might be a lot easier just to undo this, slide it underneath the crook of the knee, and then seesaw it all the way up. Our tourniquets want to go high and tight. I'm going to pull all the slack out that I can, and I'm going to get good Velcro contact on here all the way around. And then I'm going to tighten this windlass down until the bleeding stops and is controlled. Honestly, I want to go pretty tight. Like right here, I can feel like, I probably can't, maybe one more turn in there. And then I'm going to put this in the tab and secure it. And at that point, bleeding should be controlled. I've never not had a single tourniquet work, but I do know of some case studies and people like that are paramedics and corpsmen and PJs, pararescue, and the Air Force and different branches of the military, that when you get guys that have very, very developed, and women for this matter, females and males that have super muscular developed thighs, you may need 2 tourniquets. And that's why we have 2 kits in there in case you need a second, or you have multiple patients, victims. So that's my tourniquet application. I'm going to clear all my limbs. The way I do that, so in this case, maybe I saw an active bleed coming from the knee because they cut themselves on the knee. I'm going to go for that first. If I don't see an active bleed and I just see bleeding, I'm going to perform what's called the blood sweep. So whatever I do, whatever I come to first. If I come to my legs first, I'm going to do the legs. Some people do the right side, some people do arms. I just kind of pick whatever I come to first. I'm going to take my hands, I'm going to get pretty intimate with this person. I'm going to scrape down the leg, I'm going to look at my hands, and I'm going to feel. This is in case we're in a low light setting where we don't have some type of light. Like maybe we're outside at an evening event and I'm trying to get this kicked off. If I feel blood, or I see blood on my hands, or I see blood, tourniquet. I'll do this leg, tourniquet. If there's nothing, nothing. I'll come down the arm, look, feel. If I don't have anything, I'll move on. If I have something, tourniquet. Same thing on this arm, and I'll sweep all 4 of my arms. Then I'm going to come to my junction wounds. So, this is about as high up as I can get a tourniquet. I can't get any higher. So this whole area here and my shoulder girdles, I really can't put a tourniquet on that, but I need to do something. These areas with big bleeding, so basically the belly button to where I can't get a tourniquet on the leg anymore. The shoulder complex, which I draw a line from the armpit to the ear. Everything outside of that's fair game. As I creep inside there, I want to stay out of the chest. But all this area here on the torso, it's all packable. And what will happen is we'll get a puncture wound into the tissue. So maybe, like I've seen this on an agave plant. We had a guy a couple years ago fall on an agave plant, and it punctured him, and he had some pretty significant bleeding. Gunshot wounds, knife wounds, there's lots of ways. Chainsaw that gets up into the groin, kickback, something like that. Those can all be puncture wounds that get an artery. So for this, what we're going to do, in an ideal world, we want to use something that's got a hemostatic agent. So your Celox, your Quick Clot are your best go-to. We're going to take that gauze, and they all look a little different. We're going to take our finger, and we're going to stick it in this wound. Now, if this patient's conscious, they're going to be screaming, right? And that's a good thing. Airway, breathing, check. And that's kind of the attitude we have to have with it right now. And we got to tell them, like, hey, this is going to hurt, but I got to do it to save your life. When I stick my finger in here the first time, hopefully with a gloved hand, but if not, like, you got to do what you got to do. I'm not telling you guys to take any risks. We want to use precautions. In these kits, there will be gloves and things in those cabinets, so you can take 2 seconds to throw a pair of gloves on. But as I stick my finger in there, I want to feel for the palpating artery. You should potentially feel this like pulsating type of flow. If you can feel that, great, and I'm going to put my finger right on that and hold pressure. Arteries have smooth muscle in them, and when they get injured, especially if they get severed, they tend to retract up into the tissue. So a lot of our wound packs, about 80% of them, end up being what we call blind packs. And so I'm not going to feel that artery. So in the case if I don't feel the artery, cool, I'm just going to continue to shove my gauze in. So let's say this is on his hip right here. I'm going to shove as much gauze in until I can't get any more in there. And then I'm going to take whatever's left, ball it up, and now I'm going to put as much pressure on this as I can. This may require a knee. I'm going to move it to this side just so you guys can see better. But I might have to come in here with a knee and then just lean on and put everything I got on that. Because it takes a lot of pressure to control those bleeds. So again, anywhere in the pelvic area, anywhere up in this kind of armpit, upper shoulder area, the neck can be packed. Those are all our packing areas. The last area that I'm going to kind of sweep, so I sweep my groin, I sweep my chest, I turn this guy to his side, same thing. I sweep the back of his shoulders, the back of his pelvis and butt. No bleeding, cool, I move on to the next thing. My last thing I'm going to do is I'm going to sweep the torso, and I need to have skin-on-skin contact here. So this again would be like trauma types of things, right? All these will have scissors in them. I can cut some of the clothes off, or I can come up underneath the shirt. But what I'm going to do here is I'm going to take my fingers and I'm going to kind of make, I call them jazz hands or kitty paws, and I'm going to rake back and forth across all the tissue. I'm feeling for any cuts, punctures, tears. If I find a tear, puncture, or cut, I'm going to take something and I'm going to seal it. So I can use a gloved hand, I can use a chest seal that will open up and it's a real sticky gel pad I can put on there. I can use duct tape, oops. I can use the packaging this comes in, a trash bag, a Ziploc bag. The point of that is if that hole goes into the chest cavity, it may allow air to flow in there and that can collapse the lung down the road. So that's that tension pneumothorax that we talked about in the bath. So B, bleeding, A, airway, T, tension pneumothorax, and hypothermia. So then I come in here and I'll seal all that up. So I wanted to show that. I will go into a PowerPoint later that goes through all this stuff again and kind of shows pictures. But I wanted to show my demo of basically my assessment. So I'll come all through here, feeling for tears, punctures. I'll roll them onto his side. Same thing, come in here. And then the last thing I will do is put him in the recovery position. So I'm going to have Dakota come down here. I'm going to move Dummy Dan out of the way here. Dakota, can you come lay on the floor for me? Slide it back. So the way I put someone in a recovery position is I'm going to take one of their arms up. I'm going to slide this way just a little bit so everybody can see. I'm going to take this arm up just so you guys can see. The opposite arm, back of his hand is going to come on his cheek. The same side of the arm that's up, this knee comes up. This knee, the same side it's laying down. And then I'm going to roll him over so he's tripoding on this knee and this arm, and his airway's down and his head is resting on this arm. And now his airway's open, and that's how I'll maintain his airway. Especially if I've had multiple patients. Sisters, welcome back. I wanted to go through kind of our medical assessment. So you guys have already probably seen the trauma assessment where we did our blood sweeps. A medical assessment is going to be different, right? This is going to be our person that's passed out, unresponsive, unconscious, not breathing, all these kinds of things. So my circulation, airway, breathing, same. I'm going to come up, primary assessment real quick, right? I don't see anything major. I'm going to make sure my scene's safe. Nothing's going to harm me. I'm going to quickly put my gloves on, and I'm going to look for big bleeds right off the get-go. If I see big bleeds, I go into that trauma protocol. Tourniquet, pressure, wound pack, all that stuff. But in a medical call, we're probably not going to see those big bleeds, right? We're going to see heart attack, stroke, those kinds of things. So after I put my gloves on, make sure my scene's safe, I'm going to come up, and the first thing I'm going to do, brother, sister, sir, ma'am, whatever, are you okay? If there's no response, I'm going to take my knuckles and I'm going to dig right into their chest, right? I'm going to get them onto their back and dig into their chest. At that point, if there's no response, 911 needs to be called because we don't know why this person's unconscious. From there, I'm going to send someone to go get the AED out of the cabinet, the mask that's in there, the gloves, all those kinds of things I'm going to go get, right? And I'm going to open the airway. I'm going to put one hand on the forehead and lift it back. My other hand's going to come down on my side, not reaching across, but my side, and feel for a pulse in the neck. For a child or an adult, we check a pulse on the neck. For an infant, this doesn't have an arm, but they have arms coming down. I'm going to check right here on the inside of the arm. That's called the brachial pulse. So again, adult, open the airway, feel for a pulse. I'm going to come down close and I'm going to look, listen, and feel while checking for a pulse at the same time. Looking for chest rise, feeling for airflow, listening for airflow for my breathing, and I'm going to feel for a pulse. If they are not breathing and they don't have a pulse, I am going to go into my CPR. And the way I'm going to do that is I'm going to find the middle of the chest. So basically you can see here, middle of the chest, right between the nipples. I'm going to take my palm of my hand, doesn't matter which one, and you can either lay them flat or you can interlace. It kind of depends. I kind of like a half approach. My bottom hand's loose. My top hand, I interlace my fingers. I want my shoulders directly over my arms. So I have good posture. I'm not limp elbowing it, and I'm not way out far. I'm right over the top of them. And I'm going to give 30 compressions. And again, I want to go about a third or a quarter to a third of the chest depth. So somewhere in here. This particular model, you'll probably hear it click. And I want a pace of 100. 1, 2, 3, 4, 5, 6, 7, 8, 10, 11. Now, you can do two choices. If you're doing lay rescuer, you can just do compressions only. If you know how to do breathing, you can grab the pocket mask, create a good seal, and give a breath. Or for advanced ALS and BLS providers, there is a bag valve mask in there where we can do some bagging if we have more people to help. So that's my protocol. For an AED, what you're gonna see, once you get this and this gets on scene, the sooner we can get this onto the patient, the better. So we're gonna open this up, and it's really simple. Ours are very much like this. They're in a little bit harder case, so they don't come out, but they'll be attached. You're gonna open it up, you're gonna turn it on.
Adult patient. If the patient is a child, press the child button.
What will happen is, our particular models have a little handle. You're gonna pull out the pad handle. It's gonna pull cords out just like this. The case will open, and you're gonna have two pads. And you see there's pictures on here. You're gonna have one that goes in the upper right corner and one that goes in the lower left. So you'll turn it on and you'll follow the promptings.
Adult patient. If the patient is a child, press the child button.
Ours does not have a child button on it. You just are gonna leave it alone.
Patient's chest.
So, and it's gonna stay here,
and apply pads
and
on
it
the
won't
patient's
progress
skin.
past until we put the pads on. So we're gonna peel the sticker
Apply
off.
pads as shown in the pictures.
Make sure we have a good contact.
Open packet and apply pads on the patient's bare skin. Apply pads.
Now, I'm not going to put them all the way on, but you can see we have one upper right, one lower left.
Firmly on skin. Do not touch the patient. Analyzing heart rhythm.
It's important this time that nobody touches them.
Do not touch the patient. Analyzing
Everybody clear?
heart rhythm. Shock advised.
Shock is advised, nobody touch the patient.
Everyone clear. Press the flashing shock button.
So it'll flash this button, ours does the same thing. Hey, everybody clear, shocking. They may move a little bit.
Delivered.
And one of two things will happen here. Either in the first few seconds, they're gonna start showing signs of life again. You'll start seeing chest rise and chest fall. Their color will start to come back pretty quick because their heart is now working and perfusing. That is the best outcome. At that point, we're just gonna maintain them. We might roll them into recovery position. They may or may not be back into consciousness again, but we're seeing chest rise and chest fall. If we don't see that and we don't see obvious signs of life, we're just gonna continue CPR, and this machine will reanalyze every 2 minutes and give a second shock. Now, once we have the pads on, we're leaving them on. Even if they start coming back in and we see signs of life again, it is real easy for them to go back into an arrhythmia and they need a second shock. So pads are on, leave the pads on. If they wake up, just leave them here. Hopefully by this time EMS is getting close or already on scene and they'll take over for us. Brothers and sisters, I hope you got a lot out of this video. We should be putting together an email here pretty soon after the release of this video of in-person training dates to go through some of these similar things so you guys can actually get your hands on doing compressions on mannequins, using training tourniquets in real world situations, using a training AED, all those kinds of things. So I'm hoping here in the next couple of weeks to put together a training schedule with the various different CPR instructors throughout our stake. And our goal is to offer that at least once every other month and ideally once a month at the various different buildings within our stake center. So the Prescott Valley building, the Prescott Valley Stake Center, and then the Chino Valley building will rotate those. So look for, it'll probably be a Google Doc or something along that nature where you guys can just kind of sign up for any of those dates that are coming up. And as we get participants, we'll plan accordingly with bringing more instructors in and things like that. So if you guys have any questions, please feel free to reach out to me. I'll put my contact information here, but you can also find me in LDS Tools. Again, Joshua Schmidt. My wife, Tara Schmidt, is also a CPR instructor and will be helping us out. And if you have questions, feel free to reach out to me. If you're like, hey, how does this work? If the stakes have questions, bishopric have questions, all those kinds of things. So hopefully we never have to use these tools and everything goes well, but at least they're there in the event that we do need them and we have an emergency. It'll help hopefully bring our loved ones home and give us a little more time with them. So have a great rest of your guys' day, and we'll catch you later.